ways in which you're using financing to sort of promote the dual goals of improving housing and improving health. Before we do that, I'm going to go to Lisa Gomez next. But before I do that, I just want to take a sampling of the audience here. Can you raise your hand if you consider yourself an affordable housing person or a community developer or in that world? Okay, lots of you. Okay, now how about, I know there's at least one pediatrician in the room. Who else in the room is a medical person or a public health or population health type person? Oh, that's great. A little overrepresented with the housing folks, but that's really interesting to see that. Okay, we're going to do our best to keep this a kind of a acronym-free zone, you know, so when we say CDC, we mean the Centers for Disease Control, I mean, Community Development Corporation, you know, we always get confused with these things, so we're going to try to do our best to avoid all of that. So Lisa, can you want to tell us a little bit about your example?
Sure. I think it's not completely dissimilar to San Francisco. We undertook a large public housing redevelopment, actually with Enterprise as our partner, in New Orleans. Post-Katrina, the homes were not in any kind of good shape before the storm. You can imagine what they were after the storm. We're still finishing. 300 and something units on site, we're still finishing. It's an incredibly difficult process. We've been blessed to have most of our residents come back. Enterprise and our local not-for-profit did a really fantastic job of keeping in touch with people who were far-flung to Houston and Baton Rouge. And as part of this redevelopment, what we realized was that after the storm, the area really lacked grocery stores. So we were putting back residents with very little infrastructure. We're a private company, but we sort of function with a double bottom line mentality that, you know, neighborhoods need more than just bricks and sticks to make them whole and healthy. So we got involved with is one of my favorite projects that I've ever worked on with Low Income Investment Fund, and Enterprise actually introduced us to the transaction. It's a sort of a community food and health hub. We brought in Whole Foods to do an urban model Whole Foods. We call it Half Paycheck. And Tulane undertook this. There's a really visionary leader at Tulane who, in the public health school, who sort of felt that, you know, all doctors sort of just say to their patients, yeah, you need to lose weight and eat healthier, particularly in a city like New Orleans, which, you know, we love our food in New Orleans. So Tulane came up with this really innovative teaching kitchen, which they run their residents through to sort of learn about cooking and community outreach and working on health outcomes in the neighborhood, which is actually very close to our housing redevelopment. They also use it, you know, because New Orleans is sort of a convention city, they're able to sort of use it for continuing ed for doctors who are interested in this. And so it's a great little business model. We also teamed up with a culinary workforce training program, which takes at-risk youth and sort of teaches them to work in the food industry, gives them skills. And one of the great things about this is that Whole Foods is actually purchasing prepared foods from Liberty's Kitchen, which is the workforce provider, which sort of gives them a stable stream of revenue. This all sounds great. No rational person would undertake this development deal. The numbers didn't pencil. We did it because it was just something that we knew we had to do for our residents, and we saw the vision in it. But no rational person would take on a $20 million development with sort of no financial upside on the private side. There may be others, but you know, you need a balance sheet to get this stuff done. So we had a really great team of folks, and it's actually become incredibly successful. Whole Foods is expanding. The workforce training kitchen is expanding. Tulane's program is up and running, and they've actually licensed this curriculum to other medical schools. So it's great, and I think, you know, and I feel very fortunate that I was able to do something that made absolutely zero financial sense, but that's not a model, you know. So, but, you know, we actually also were able to help our residents in our Lafitte public housing development get jobs there, and Whole Foods has hired from the community. They regularly post, so it's really created synergy. But in order to be able to make this stuff work, you need to be masochist, and you need to be able to sort of take on an incredible amount of brain damage. So I guess my plea to, my plea to everybody on the health and community development side is like, these funding streams are incredibly rigid, they're incredibly complex, and you have to be able to layer a ridiculous amount of stuff together to make something work. And in a brave new world of health and housing combined, I think there would be this acknowledgement that there are these connections and that there is a need for more flexibility, like New York is starting to dabble in Medicaid redesign, which allows Medicaid funds to be used for housing to sort of address some of the needs that we're talking about. So I think we're at a nascent stage. I think there's more to do, but I do believe there is an acknowledgement that this kind of thing is needed.
So thanks, Lisa. And I think it's interesting how in both cases, you and Lisa are talking to us about using existing programs to achieve multiple goals, right? You've heard a theme here so far about both focusing on the people and the place, right? Which is something that it sounds relatively straightforward and commonsensical, but it's so hard to do, right? When you're actually in the midst of it and to get it paid for. There was a Federal Reserve Governor, Elizabeth Duke, who had this one line in a book we published a few years ago where she said, there's a long-running debate between whether our policy should focus on the people or the place, and I'm here to tell you that debate is over and both sides won. And so you're hearing that we know that's what we have to do, but it's a real obstacle in how to do it. It's very hard to get those funding streams to harmonize. It's very hard to figure out. I mean, and what we often joke in these instances where you have someone like Ann or Lisa is that it only seems to work when you've got a charismatic super genius who has a close friend who's a billionaire, because that seems to be what it takes to overcome the systems that are so messed up. So, Ian, we're going to switch to you and just think a little bit about how can we make it easier? How can we make it easier for Ann and Lisa to do these jobs that are so, I mean, dealing with the neediest people imaginable, the communities that are the most hard hit by recession and disinvestment. How do we, and let's be mindful too of Todd in Philadelphia, where we think about those massively expensive visits to the emergency room. I mean, the money's around, right? It's sort of why my motto has been for a long time that the status quo is stupid and expensive, right? That there is money there, but how do we get it to the right places at the right time and make these people's lives a little easier?
Sure. Thank you, David. So my comments are actually going to dovetail directly on Dawn's. So I think maybe I'll start by sort of addressing and this is really to your question, what is the problem ultimately that we're trying to solve? And I think, from my vantage point, and Don did a great job of highlighting this in his presentation, we need to spend less money on healthcare and more money on the social determinants of health. And that could be housing, it could be other investments in the community. So that's the challenge that we're trying to solve. And we spend a lot of money on healthcare. We spend about $3 trillion a year on healthcare. So there are substantial resources that could be captured and used to invest further upstream to reduce the need for expensive healthcare down the road. So I think there are two major impediments to moving to that new paradigm. And Don mentioned one of them in his presentation, which I will rephrase as the they're not buying what we're selling problem, which is to say that public and private insurers, whether that's private insurance companies or Medicare or Medicaid or others, don't necessarily believe that a investment in something like supportive housing will save them money in the long run. They may believe it conceptually, intellectually, but they're not willing to risk the chance that making an upstream intervention, an investment in an upstream intervention, won't actually translate into better health for that target population, which would then lead to reductions in cost. So that fear of, in effect, double paying is enough to keep most risk-averse health payers from investing in the social determinants at scale. I agree that the ACA is encouraging a lot of these payers to think more deeply about investing in the community, but they really don't know how to do that, and they don't have a firm understanding of what organizations are going to produce results and what organizations may not. So I think that's problem number one that we need to solve, this sort of risk or perceived risk of investing in the community. The second challenge, which I think is equally important, is that all of our money is tied up paying for treatment to serve the needs of people who are sick already. So even if we bought into the idea that we need to invest in something like housing or supportive housing or a community investment, we don't have any money because we're spending all of our money on healthcare. So it's these twin challenges that I think are keeping us from moving in the direction that Don and David, you just mentioned. So there's a new tool that some of you may be familiar with that actually solves both of these problems, and that's going to be sort of the bulk of my remarks today. That new tool is something called Pay for Success financing, otherwise known as social impact bonds. This may be a familiar tool to some of you in the room, but I'll just spend a couple minutes explaining how it works and walk you through an example of how it's been used to invest in supportive housing for the chronically homeless in Santa Clara County. So the way to make a pay-for-success transaction work is first you need a performance-based contract between a nonprofit that produces, in this case, a health outcome that is valuable to an end payer. So maybe that's Medicaid, maybe it's a public health agency, maybe it's a private insurer, maybe it's a hospital system, it doesn't really matter, as long as the outcome that is being produced by the nonprofit is valuable to that end payer. They enter into a contract, they agree on the terms of delivering that outcome, how long is it going to take, how significant of an improvement in the health of the target population is needed, what are the evaluation parameters, is there going to be a randomized control, et cetera. All of that is written into the contract. And importantly, just to underscore sort of the reason we call it pay for success, the end payer only pays for success. So if the nonprofit fails to deliver the outcome as described in the contract, then the end payer is off the hook, whether that's Medicaid or a public health agency or a hospital system. So that's sort of the transformative element number one of pay for success. The other is the financing piece. So this creates a challenge for nonprofits doing this work because they only get paid at the end of the process and only if they succeed. So that creates a funding gap for them. They have to keep the lights on, they have to run their programming, so they need money today, they need working capital today to run those programs until they succeed and deliver the outcome that the end payer is going to pay for, at which point they can reimburse whoever it is that lends them the money at the outset. So that's the investable opportunity in pay for success. So that could be a bank providing those upfront funds. It could be a foundation with a program-related investment. It could be a high net worth individual. All of these have participated in pay for success deals so far. But the point is they provide the upfront funding and they bear the risk in most cases that the nonprofit will or won't deliver the outcome that will trigger the success payment. So those are the two elements of pay for success. They solve both of the challenges that we're having with this conversation today, moving to the new paradigm. Really quickly, and I know we're running short on time, let me just walk you through a recent project that actually used this mechanism to increase funding for supportive housing for the chronically homeless. This is the latest pay for success deal. There have been 8 in the country so far. This is in Santa Clara County. Santa Clara County entered into a contract with Abode Services, which is a homeless service provider, that basically said you have 6 years to provide supportive housing for 150 to 200 chronically homeless individuals, and to the extent that you can keep them stabilized in housing for that period of time, we will make success payments that gradually ramp up based on your ability to keep them stabilized for longer periods of time. So if you can keep them stabilized for 3 consecutive months, you get a $1,200 payment per person. If you can increase that to 6 months, that increases. If you can do it 9 months, it increases. A full year, it increases. And then every month thereafter, success payments are made. So that's the mechanism in the case of Santa Clara County. The senior lenders in that project are the Reinvestment Fund, which is a CDFI based in Philadelphia, and the Corporation for Supportive Housing. They're providing collectively $1 million of the $6.9 total investment that's needed to provide supportive housing for 150 to 200 chronically homeless people. And the remaining $5.9 million is being provided by a coalition of foundations who are supporting different aspects of the project. But again, Abode is only repaid, and the investors in this project are only repaid if they can deliver stable housing for this chronically homeless population for a long consecutive period of time. So this is being done. There is precedent for it. I think that this mechanism gets us out of this box where we can't pay pay for housing, even though we know it makes sense and it's good prevention, by primarily resolving those two challenges of not understanding what this is and not having the money up front to pay for it. And I'll stop right there, but
Sure. No, that's great. Thanks, Ian. And so here we have three examples, people using existing HUD dollars. HUD has a annual budget about $40 billion, something in that neighborhood, I think. Of course, the RAD program isn't that big, or the rental assistance program is not that big. We've talked about new markets, tax credits, low-income housing tax credits. That's probably about, in terms of net equity, maybe $15 billion a year. It's also, in both cases, married to debt from banks that are motivated by the Community Reinvestment Act. That's probably somewhere north of $100 billion a year in sort of focused investments into low-income communities. And what Ian's bringing up now is this idea of maybe tapping even more outside, sort of off-balance sheet, if you can think of it that way, sort of money that can be used for some of these upstream interventions that particularly in this case for a population where you're actually managing, in a sense, a chronic issue. And you can see a lot of sort of pay-for-success strategies focusing on formerly homeless, people with 2 or 3 diagnoses, frail elderly, people who you're trying to manage the disease somewhat. So these are sort of great examples. What I'm going to do, I'm going to come back to Ann, 'cause I feel like I didn't give you enough time, but I want to intersperse that comment with some questions from the audience. What I'm going to ask you to do, I'm going to take a group of 3 of them just really quickly. I don't know if we have microphones to run around. Is that? I think we do, yeah. So I'm getting that sign that we do. So we have some folks, Federal Reserve staff are walking through the room here. So just raise your hand, and I want to just get 3 questions quickly on the table for our panelists. So can you go ahead? Here's 1, then 2 down here, and 3. And just real quick,
Okay.
and then we'll...
Bob Zdenek, NCRC. A question for Ian about pay for success. If I understand pay for success, it seems to be more like large-scale public housing unit projects or low-income housing tax credit. Here's the question. If you're working on aging a community or helping adults who are low-income stay in housing through the intervention of housing modifications and health, it's a great example in Baltimore. Can pay for success apply to that? And then the other part of the question is, you're doing some of the most innovative work around CRA performance. You're beginning to expand how CRA can be counted under the service test and lending test, and how that ties to the housing health nexus.
Good question. And we're going to hold. Yeah. Don't respond yet, Ian. Next question over here. Who is it over here that had their hand up?
Yeah. Hi. Thank you. The question also goes to Ian about the social impact bond. So how do you see that not undercutting non-for-profit communities? I mean, you were using the examples of insurance companies, for instance, paying for public transportation. If you were to make, if you go into to the market and you invest in equities or bonds, you don't get your money back, right, if the investment doesn't work out. And it just seems like somehow contradictory to me to be not paying the nonprofit for what they may have tried to do with very difficult populations, and not taking the money from the people who have the money, which are like insurance companies. So the question is, how does that not undercut non-for-profit?
Okay, thank you very much. We'll take the 3rd question here. This gentleman in the middle.
So again, it's a pay-for-success question. I see how pay-for-success works with a very narrow band of individuals who are deep-end expensive, where all of the savings is to one pocket, but it almost triples the cost of interventions. And my question for you is, how do you do prevention where the savings are to multiple pockets, where no pocket feels sufficient investment? And how do you keep the nonprofit from buckling?